So I'm excited to really kick off the program, introducing our first moderator for the panel addressing infectious disease. Please join me in welcoming my colleague from the Department of Community Health Sciences, Dr. Michael Prelip.
Good morning, everyone. It's so exciting to be here, and James and everyone who put this together. What a great first thing to be doing, and really excited to be part of 60 years. I was doing some math, and I've been here longer than that, longer than half of that. But I was thinking, I'm looking around, there people have been here even longer than me, and so I'm so glad to be part of this today, and really super excited to be moderating the first panel, which is focused on infectious disease, where we have three great presenters, Dr. Rachael Jones, Dr. Alina Dorian, and Dr. Pamina Gorbach. Clearly, we all knew the importance of infectious diseases before COVID, but the exclamation mark has been put on that importance in the last couple years. So I think I'm charged, and the panelists charged, with being great role models today regarding timing. And you have scared me so much with all the emails about making sure everyone's on time. So we're going to go ahead and get started, and we're going to begin with Dr. Rachael Jones, who's the professor and chair of the Department of Environmental Health Sciences. Welcome, Dr. Jones.
So just for the timing, am I going to get, I can read the clock here. All right, so I'm the only speaker today that did not present slides. And last time I gave a talk without slides, it was a bit of a disaster, and I thought they would never invite me back to the conference. But they did invite me back, so I thought I would blaze this trail again today. So I actually work in the area of occupational health, and as COVID highlighted, healthcare workers and other workers get diseases at work. We get patients coming into hospitals with infectious diseases like COVID, MRSA, tuberculosis, HIV, hepatitis, which puts healthcare workers, including physicians, nurses, environmental service workers, other specialist technicians, basically, even people who service equipment, clean rooms, at risk of exposure and acquisition of these infectious diseases. But this spans beyond healthcare settings, but I'm going to focus today on that. Now, the Occupational Health and Safety Administration is the primary body that tries to protect workers in the workplace, but they have really struggled to regulate infectious diseases. So we do have a standard that was created related to bloodborne pathogens. The organization attempted in the 1990s to create a standard for tuberculosis, which failed. They issued some COVID regulations, which had very mixed success and mixed reception. And they have been working for the last 15 years on a more comprehensive standard about infectious diseases in healthcare, which I've been engaged with for the last first back in 2014, 2015, and again today. That standard would create a programmatic requirement for healthcare facilities to identify opportunities for exposures of their personnel, assess that exposure and risk, and then identify prevention strategies. And my role in this rulemaking process, if you're not familiar with it, is that OSHA doesn't just set regulations based on health. They also have to consider costs and benefits. And the challenge is, what is the cost and benefit of requiring additional protections for healthcare workers? Well, it would be easy if we actually knew how many healthcare workers get diseases at work. And then we could estimate how many of those diseases might be prevented by the regulation. But the fact is that we really track almost none of these diseases among healthcare workers. The only thing that is actually surveyed is for tuberculosis with annual screenings. Any other disease, if I, for example, was a healthcare worker today and got COVID, they would probably tell me it was not work-related, even if I had been providing care to COVID patients. And so we really don't understand the burden. As a result, OSHA has asked us to work using a quantitative microbial risk assessment framework, where we try to understand how many people in the general population have the infectious disease, how many go to healthcare facilities of different types. When they're there and sick, how many times do they expose healthcare workers? What is the exposure? What's the probability that those individuals get the disease? And then aggregate that to to understand the national annual burden of these diseases in healthcare workers. And we run those calculations using models that consider current practices that might prevent infection and hypothetical scenarios, what will happen when the OSHA regulation passes. And then OSHA uses that information as the cost-benefit work. So back in 2014, 2015, we started this work for OSHA, and we studied influenza, tuberculosis, norovirus, MRSA, and a couple other diseases. The rulemaking process at OSHA now takes about 20 years. So when they passed the silica rule a couple years ago, people had started doing that as their first task when hired at OSHA and then retired by the time that the rule was passed. So the infectious disease rulemaking is about in year 16. They did have an interruption during the Trump administration, during which time OSHA has had to stop activities on this rulemaking process, and also most of their personnel retired. So we now have new personnel at OSHA, and they're reviving this rulemaking process. And me and some students and postdocs here have been tasked with reviving this work and looking at COVID-19, strep, for which we're currently having an epidemic, and a couple of other organisms. So OSHA keeps working. They're very dedicated personnel who have many challenges and barriers to their process, both with the internal requirements for rulemaking and also in anticipating litigation. And it's been really exciting to be able to participate in this work, because sometimes I feel like our research, we write, we publish, and then what happens with it? And this has always been really rewarding work for me, because it has a direct benefit, delayed, but you do know that there will be a direct benefit. And with that, I will pass an extra minute to my colleague.
Our next panelist is Professor Alina Dorian, who's an associate professor in the Department of Community Health Sciences, as well as our associate dean of public health practice and the associate dean of equity, diversity, and inclusion at the Fielding School of Public Health. Please join me in welcoming Dr. Dorian.
I am the exact opposite of what Dr. Jones just did. I have 7,000 slides. So we're going to try to run through them really quickly. I'm going to talk a little bit about the work that we did during COVID-19. It's much less a story about COVID-19, and it's much more about mobilizing, really getting things done, critical things under extreme conditions. And I just want to remind everybody in this room, we were all there together. March 2020, right? What were we doing? What was each and every one of us thinking? What did we know, right? We were concerned professionally, personally, uncertainty, no masks. Should we print them on 3D printers? Sanjay Gupta was washing his groceries on TV, right? What do we do? National context, totally confusing. 118 confirmed cases. A few weeks later, 428, we were at already over 1 million confirmed cases. And we were talking about that importance of isolation, quarantine, concentrating really on that core effort of contact tracing and case investigation, right? What does that look like? So that first week in May, Dr. Prelip and I received this call to action from the governor via his press conference announcing that UCLA, UCSF, and the state health department will be mobilizing and training 10,000 persons for a public health workforce of contact tracers and case investigators. And in that first week of May, we stood up what we call the largest, quickest mobilization and training of a public health workforce ever in history. I'm not sure if that's true, but I'm sure we're very close. We can't be super off. And we started the VTA, the Virtual Training Academy, which morphed into much more, hence the plus. And truly, we were building that plane as we were flying it, moving mountains to try to save lives, constantly monitoring, evaluating our work so we can adjust and adapt as the ground was truly shifting under our feet. And in that first 8 months, up until 2020, we not only trained cadres in CT and CI, contact tracing case investigation, but really quickly we realized we needed to add outbreak management teams and training around that, Our role in schools, we trained school specialists about closing schools, opening schools. Really, we were in that effort moving forward. We quickly added cultural humility to our training, and once vaccines were there, we rolled out vaccine communication training for all local health jurisdictions moving forward. I love this slide because it really talks about how much work we did. Every single week, we provided rigorous and holistic training that not only increased knowledge, it was all about increasing skills, right? Having people be able to do the work and the confidence to be able to do that work. They were frontline workers at this point in time. And we basically had close to a 20-hour training session per individual, where again, we would break them down into small facilitated groups so that they would build skills week after week. And you can see 5 weeks in a row, we were training over 600 people in that week and moving them forward. We trained across the entire state of California, all 61 local health jurisdictions. We had employees out into that workforce. And the most exciting thing was it was non-traditional public health workers. The state had to redirect 5% of its workforce from different state agencies into public health to be able to do this. So we were training librarians, Parks and Recs, Caltrans, corrections, and they did an amazing job. We were super blown away by the amount of work we did in that first year. This is how many individuals we were able to train. And I think the other piece that's really important was that communities of practice. Again, these are frontline workers. They were dealing with the sick, those that were exposed, people who had lost jobs, deaths in families, and really trying to bring them together and create sort of this united, motivated solidarity in this workforce was really important for us. Wellness for them so they could provide wellness for others. And we spent a lot of time in doing that. Million lessons learned. I would actually say lessons highlighted, right? In just what we did. And I would say probably the biggest lesson, relationships. It's all about those relationships, right? Public health is not an isolated discipline. And being able to have those linkages, partnerships, connections, I always say that's the art of what we do, which rounds out the science of what we do. And making sure we have those beforehand to nurture and create all of those collaborations. Collaboration's a verb. You gotta work on it. And it's something that we needed to do over and over again. At the same time, boom, we were in Armenia doing the same work, trying to build the national case investigation and contact tracing work in Armenia at the same time, collaborating with the American University of Armenia and the Ministry of Health of Armenia, as well as the Ministry of Health of Artsakh. We started working in March, providing technical assistance. In June, we started rolling out this. And then in September, the war hit in Armenia. So not only were we dealing with COVID, but Artsakh was attacked by Azerbaijan, even though the UN Secretary General's Resolution 2532, which came out in March, stated that there should be a global ceasefire amid the pandemic. But unfortunately, even though that was endorsed by all UN member states, the UN and the world was not able to stop this attack. And it changed the face of the game in trying to do this work. So the reality in Armenia was issues in government, which we see, right? Trust, centralization. It's a very centralized post-Soviet health system. Lack of transparency, lack of data, and moving forward. No capacity, no competency, very limited in everything that we had to do. But we also had no electricity. We started having hospital beds that were overrun, not just with COVID, but war, trauma. And what did that look like? We had displacement. In the beginning, everybody was in bunkers. Everybody was, once the roads opened up, 94% of Artsakh moved into Armenia, then having to be able to provide both, again, COVID as well as war-related information. This is one of the epi curves that we saw, with the red being right during the war, how the cases increased, but no good testing. No access to the individual. So we don't know how much of this is actually underreported, but also how much of it is just directly because of the war. And we say stay at home to remain safe, but how can you stay at home when you have no home? They were in the bunkers. but we were still COVID testing in these bunkers in Artsakh moving forward. And the last thing is Armenia is a very social place, and there were tons of people dying. So at funerals, nobody wore a mask. Everybody was hugging, everybody was kissing. They had priorities over COVID in moving forward, and they were out protesting, hoping for the UN to step in and be able to stop it. Last second, I know I see my stop coming. Armenia had a genocide, 1915. Monday will be the commemoration of the genocide. These were the pictures plastered everywhere. It was a feeling of a second genocide coming when the displacement was happening, and there was sort of this generational trauma. And all of our work that we started doing around masking, vaccination, etc., came back to trying to keep the soldiers, their sons, their fathers, their husbands healthy, and what that looked like moving forward. Last thing, war ended last December, but since this December, last 130 days, Artsakh has still been in a blockade, no medical aid going in, no international assistance going in. So we're still in this place and still dealing with all of these things, not to mention other diseases, other chronic diseases, and just the mental health of the population. Done, boom.
And the third panelist, very excited to introduce Dr. Pamina Gorbach, who is professor in the departments of Epi in the School of Public Health, but also in the Division of Infectious Diseases at the Geffen School of Medicine. Welcome, Dr. Gorbach. Yeah, that's right.
Okay. I am the only card-carrying epidemiologist here today, so I'm going to have to show you some slides about infectious diseases. So I'm going to talk about not just this pandemic, but I'm going to talk about multiple pandemics. And I'm going to remind you that the topic I called was syndemics, because we have had the confluence of multiple epidemics of infectious diseases. So let me start with HIV, which is the first pandemic I worked on, but not necessarily the first pandemic there is. Just to remind everyone what it is, HIV is human immunodeficiency virus, and there is still no effective cure. Once people get HIV, they have it for life. There is very effective treatment. So now with good care, people now are what we call untransmissible. They can be if they become undetectable, which is a real game changer. I just want to remind people how this infectious disease is transmitted: sexual contact, sharing needles, a mother to body during pregnancy, birth, or childbirth, not by air or water, saliva, sweat, or tears, insects or pets, or sharing toilets. But where are we with HIV? I told you I'm going to go fast here, 7 minutes, cover 3 pandemics. Globally, we have 38 million people living with HIV, 38 million people. This is 2021, where we have the latest stats. 1.5 million people newly infected with HIV in 2021. So this is still an ongoing pandemic. And 650,000 people who died from AIDS-related illnesses. But we have 28.7 million people accessing antiretroviral therapy. Just to put this in context, 84 million people have been infected with HIV since the start of the epidemic, and 40 million people have died. But this is a lesson of treatment and how treatment has saved lives. And so what we can see is the curve here of how people were dying until we introduced medication. It was introduced in 1995 when I got my degree, which was a real game changer, but it wasn't until really 2005 we saw the curve come as the treatment became rolled out globally. Huge difference, and what would have happened if we hadn't had treatment is the red line. But we got a long way to go. This is not a pandemic that is over. We have not solved all the problems. This shows you where we are in the United States with HIV right now, and what's called the care continuum, which is that although most people, 87% living with HIV, are diagnosed, we still don't get them into care and treatment, and we only have about 57% who are virally suppressed at this point. So that's a lot of work we still have left to do. So what am I going to tell you? I'm going to tell you a little bit about the work that's being done here by me and my group. There are many other people here at UCLA who do incredible work on HIV, and I wish I had time in 7 minutes to acknowledge them, but I don't. So I'm going to talk about my work. So I work on, as I said in the top, bugs, drugs, bugs and drugs, and sex. I mostly focus on drugs right now, and I started doing work on mostly men who have sex with men here in Los Angeles, and there our epidemic is really driven by methamphetamine use. I also do a lot of work, mostly recently, on cannabis and inflammation, and I have a couple new projects coming in, really exciting, looking at cannabis and HIV. sex, bugs, and drugs. So I'm going to talk a little bit later on some of my current ongoing projects. But my main project is this cohort, which is a research platform that is now in its 14th year, which we call the M study. We have enrolled over 571 men. We have lost a lot of our guys during the pandemic, the COVID pandemic, but we're trying to get them back. But just so you can see the numbers here, we have a lot of substance use, and that is what we're looking at, is really that's syndemic of substance use and HIV here. We have had about a 5% incidence rate, which is people that got newly infected, and 17, these are young men who have died while we've been following them. I just want to let you know we have a huge biorepository. So this is a research platform. It's not a study, which means we encourage a lot of other people to use our specimens and do research building off of them. And this is an example of just what we've covered and who else is funded to do this work. And we have over 26 active studies with this, but we've had doctoral dissertations and postdocs and also real careers launched from K Awards to now R01s from some investigators across campus with this. And I need to acknowledge our community partners could not have done this without the LGBT Center that has been a partner of mine for over 20 years and is the site for our people living with HIV. Also the Vine Street Clinic, which is the only UCLA outpatient research clinic that actually in 2006 I opened with my co-PI of this project, Steve Shoptaw, but he has taken it over, and it is a really active research site out in Hollywood, and we see all of our people without HIV living there. Two really exciting projects that are starting up right now that I'm doing. One of them we're awaiting the money to hit us, but they made us start the work, is going to be a virtual cohort of over 1,000 people across the United States who are living with HIV but not suppressed. These are the people left behind or who are missed. And we're going to try to reach them virtually and follow them. And another one is looking at increasing our rigor and measurement of this synergy of substance use and HIV. I have a new grant coming in with Dr. Monica Gandhi at UCSF, where we're going to be learning how to use hair to look at substance use and do rigorous assessments. So I'm going to talk quick about COVID-19 because there was the next pandemic. This is where we are with COVID-19 as of the latest dashboard. Looking at this globally, just remember how many cases we have had here, a lot, and where it is in the United States. So certainly we have gone through a journey with this pandemic. It is not over, but yes, we have low cases right now. I still wear my mask in these large settings. I thought I could avoid getting COVID. I got it. Even with the mask on all the time, it's going to hit us, but let's do our best to try to keep it at bay still. And looking at that syndemic of COVID and substance use, we actually put out with my colleagues, 21 papers in a special issue on the effects of COVID among people living with HIV and who use substances. And then I'm going to end with the latest pandemic, which is Mpox. And I can do this in a minute. Most cases have been among men, mostly among MSM globally and in the United States. The lowest vaccination rates, there is a vaccine for Mpox. We don't know how long it lasts for. We don't know how effective it is. We are doing a study to try to figure that out with Annie Remoyne. The lowest vaccination rates are among people of color. Most reported exposure settings are in party contacts. This is what the epidemic curve looked like for Mpox. We are nervous about this year and this summer, and so we'll see as the party season starts if we can get out there ahead of it. We're trying to get materials out to the Pride festivals and other activities going on. I've had over 30,000 cases in the United States and 42 deaths. This is the state counts. And again, our work, what are we doing here? Working with Dr. Annie Remoyne and Dr. Dave Talon in infectious diseases, or actually he's in the Department of Emergency. We've got a really exciting set of 4 projects coming in with CDC funding. We're looking at stored specimens that we had from our biorepository. We're looking at vaccine efficacy. We're looking at surveillance in 4 major emergency rooms, and we're looking at surveillance prospectively with sex workers. So, infectious disease represents syndemics. That's the story here. Who has the highest infection and mortality rates? People of color, people in less resource settings, people with other conditions such as substance use, and sexual and gender minorities. That is the story across these pandemics, with the exception of COVID that really was broad-reaching. Who is the last to receive or adopt prevention and treatment? And that is people of color, people in less resource settings, and people with other conditions such as substance use. So that is how our work needs to have a syndemic focus. And this is just to acknowledge the incredible core scientific team that I'm lucky to work at in my research center. And I couldn't do the work without them. Marjan Javanbach here is the co-director, and I really couldn't without her. And that's where we are.
Okay, so it's time for questions to the panelists. Yes. Perfect.
Maybe all of you, but Dr. Gorbach, Dorian, Dr. Dorian, with the COVID-19, all of your interventions, are you implementing or strategizing on like a playbook for future pandemics?
Yeah, that's a great question. So just my training is in disasters. That's pretty much what I've done, and really working with local health jurisdictions and really understanding how to do all hazards planning, right? And so we were kind of planning for a pandemic, but not exactly. But now we've done a lot of work, both in the sense of toolkits, but also after action reports. We've also been asking local health jurisdictions to do after action reports around their, how they responded, both within their jurisdiction, but also within those EOCs, those emergency operations centers, where they had to be able to be a voice for the other state agencies in doing that. So yeah, we've been working on a lot of that. Thank you.
Great. Yes, James.
So my question is really about, it seems that things are accelerating. Our awareness of these infectious diseases as well as our need to respond to them. How do you shift focus in order to do research in real time? That's not the way many of us were trained.
I'm not the researcher.
Well, I would say that with the COVID pandemic, because I do a lot of work on occupational health and respiratory protection and other types of interventions that would try to reduce transmission or exposures to the disease, it was very hectic, I would just say. And it was difficult because at the time of the pandemic, I actually didn't work at UCLA. I worked at the University of Utah, but I think the situations are quite similar in that, you know, we had to shut down our laboratories for a period of time. Because of the topic of our work, we were able to get special permission to open up and resume our research earlier than most of the other investigators on campus. But honestly, like, people at the hospital were so overwhelmed, they didn't really want us there, you know, to bring in sampling equipment to actually measure pathogens in the facilities. They were just really overwhelmed by that. They wanted more technical support for like how determining, like, should they clean respirator, you know, should they reuse N95 filtering face piece respirators? And so I would say that in that first year, we did a lot of things that weren't really research, but was more like technical support based on our research training and knowledge to be able to support practical applications. And it was only in the tail end, you know, by 2021, 2022, that research opportunities became available, or there was capacity to do research, because we weren't just doing emergency response. And so then we were able to get grants to start developing some technologies that had emerged as candidates during the intervention. So like, we had this grant from the Department of Defense to develop a ventilated aerosol containment device, and those had become popular, these little plexiglass boxes, which don't do anything, but they look nice. People feel like they do something, but it has no actual impact. So anyways, we're trying to work on developing one that does something. So I don't know, I would just say, working in the area, it was a bit overwhelming, and it was really still an emergency response function for quite a while.
Okay, well, I can talk from the research perspective. What we did is we haven't gotten any sleep in a couple years. I would like to have a summer without a pandemic. You know, Mpox last summer was like, really, another epidemic? But yes, we have. What we have done is leverage our resources. We learned an incredible amount from the HIV epidemic, and that's why I started by talking about the HIV epidemic. And we used and mobilized and leveraged the infrastructures that we had built for HIV and COVID-19. So that's why we were able to launch, I didn't talk about the survey we did among people living with HIV and people who use substances. We were able to change our research settings to be remote really quickly because we had an infrastructure and experience. So we're trying to do that this summer by getting ahead of Mpox and not being caught with our pants down, so to speak, in a lot of ways, and get the word out there. But again, we have an infrastructure. And so what do? We pivot. And we use that infrastructure and lessons learned, and our teams have been incredible in responding to the new issue.
Great, thank you. Yes.
Hi, Dr. B. Thanks. Thank you so much for speaking about monkeypox. I was wondering, you talked a little bit about the infrastructure that's set in place. Will there be more access to vaccines this summer? I actually went and requested a vaccine, and I was told that I was not able to get one. And I was wondering how we combat stigma when priority populations are prioritized, but then some aren't. And how do we kind of go about lessening that stigma and getting people vaccinated that need to be or want to be?
Right. Well, we're trying to get ahead of that right now. In fact, the last week we've spent time, Dr. Moyne, who I collaborate with, is at the White House today talking about Mpox. And with other colleagues across campus, led in the social work setting, they're starting to do projects at all the upcoming Pride events with information about where to access Mpox vaccine. The problem is when there is resource limitations, you do have to prioritize those with the highest exposure and the highest need. And so that's why maybe you couldn't get one, but we tried to get one out to the communities of need and where people are going to the events where they're more likely to encounter Mpox, those with the highest exposures. So there has been a little bit of prioritization that happened with this limited resource, but I think that will be better this summer. One of the studies we're doing is looking at vaccine efficacy, so we don't really know how long the vaccine works for. So people that were vaccinated last summer, we're not sure the level of protection that they have this summer as we come into the height of sort of the party season. We just don't know. But I can tell you that right now, LA County and the CDC, we are all working to try to get more vaccine available and out there in anticipation of the summer.
Thank you.
Great, thank you, Colleen. Eric?
Mia, how does the drug use, what do the numbers look like among men who have sex with men in the last few years, the drug use, compared to the communities in general?
I don't have an hour. Have we made a change? I mean, is there less substance use?
Right. And how
Not really. And have the drugs changed? Not so much. I mean, we have had fentanyl. So we have not so much here in Los Angeles, but, because I work with some national groups, the fentanyl epidemic has been tragic, and we've had more and more deaths due to overdose because of that. So what has changed is more overdose. And what has changed is what's inside the drug. So actually, I don't have time to talk about it, but we have a machine out in the community right now that provides drug checking of the drugs to people. And so we're out on the street at Street Outreach with the needle exchange groups now 2 to 3 times a week, working with Dr. Chelsea Shover, who is my former doctoral student and now assistant professor in GIM here at UCLA. And we're trying to get more ways for people to test their drugs to be able to use them safely, an approach known as harm reduction. But we still have lots of people using drugs. Have we made progress in less substance use? Not really, I have to say. Depressing, but true.
Great, thanks. Yes.
I wanted to follow up with Dr. Nasico's question on the current day research and knowledge, and then we hear about a federal judge in Texas denying PrEP coverage for people with Medicaid. More and more equity issues are coming up in red states. Does UCLA or do your departments come up with public statements or opinions about these things just to give a national image of what we know to be true?
So I'm just a simple country epidemiologist. That's what I say. And we have people whose job is communication, and we have a chair in that, and that's Dr. Annie Remoyne in infectious disease for our department. And I can see, the school probably makes public statements. I just do the research and let other people do the policy, and it's frustrating. But I don't do it all. Does somebody else want to talk about policy and communication? Where's Annie when we need her? You can see her on the news. She is all over the news. She's at the White House today, so we do that in the school public health, and we have an incredible communicator who does that for us. And so I always defer to her and say, if you want somebody to talk to the media, talk to Dr. Remoyne. I'll just sit here and do the studies.
I have done media work over the years, mostly work because of my individual expertise. So as a faculty member, we don't really put out public statements representing the institution.
Yeah, I was going to say, I mean, we do a lot of that kind of media outreach, especially around programming that's in communities and globally. But usually it's not necessarily a policy statement or from the entire department. It's usually as a subject matter expert providing information.
I would also, one other thing I think many people work through, like their professional organizations to make those kinds of policy statements. So, I'm in a group with the American Industrial Hygiene Association, which is my primary professional organization, about what we consider our role as professionals in creating decent, healthy work, which is a little bit outside our normal professional practice, but we really want to raise awareness and push boundaries to acknowledge that somebody who is trained as a kind of disciplinary technical professional has roles in extending their professional practice and advocating to improve equity in work.
Oh, Dr. Deedles.
Impressive presentation. I wanted to comment, if I could, on the HIV/AIDS. As you point out, Dr. Gorbach, it's still on. It's still going on. We're still getting a lot of new cases. We have a lot of preventive strategies that we thought of. And I think we've been successful in terms of treating HIV and AIDS. But I don't think we've been quite so successful in terms of prevention, despite the things like treatment as prevention and prophylactic use. What do you think the barriers are that are continuing, and what are your suggestions for overcoming those barriers?
Again, I wish I had an hour. I'd be happy to do it. I think that we have actually made some incredible strides in prevention. And I think that there are some new technologies that are coming out. We have pre-exposure prophylaxis, but a real game changer is now that we're going to have a long-acting injectable for pre-exposure prophylaxis, so people can get an injection and then be protected against acquiring HIV. We also have injectables for treatment, so that we can really get ahead of getting people undetectable, which means untransmissible. I have to remind people that it's what we call U equals U. If we get people who are living with HIV undetectable, they do not transmit. So we have some very effective strategies. People are left behind. And that is our new project, which is about trying to reach people, we call it EpiLove, across the country who are left behind, who are not virally suppressed, get them on treatment. How do we do that? Who are the people left behind? People with substance use, this is the pandemic. People with mental health issues. People who are in really low resource settings who can't access these methods of prevention and treatment. So what do we have to do? Roll up our sleeves and keep doing the work. I do think we've made some incredible gains in terms of prevention, but we have to keep going, and some of these new technologies are really gonna, I think, be game changers.
Well, I have a question. Since we're at a school of public health, and one of our main tasks is to train public health researchers, public health practitioners, and kind of thinking about this time right now where we lived for the last 3 years in a time of unprecedented funding for public health. That seems to be drying up, especially in the state of California, where public health funding is being slashed in the next fiscal budget. So in thinking about that, in all of the 3 departments represented here, there was a really important role for epidemiologists, community health folks, and environmental health folks. And it was everyone needed to come together to work together. And I'm just interested to hear what you think we should be doing here to be training our students to do collaborative research and collaborative practice efforts, so that we are quicker and better in a time where we don't know what's going on and there's limited resources. That was a hard question. You're going to need 2 hours for that, Dr. Gorbach.
I'm going to need 2 hours for that because, again, coming back to my really main hat, which is practice here in the school, really thinking about practitioners and making sure that our students feel, again, not just having the skills to go out, but confident in going out and being able to do the work that they're doing. I think just coming back to the opportunity we had right when we stood up this workforce, the training workforce that we were putting together, we were able to immediately hire 40 of our students and new grads to be able to be in this program. And the kind of experience that they received in actually doing the work, creating curriculum, being able to just quickly respond was amazing. But it also made us start really thinking about how to create those opportunities, not when there's a pandemic, but all the time, right? Really having those experiential opportunities, not just for our students, but our recent grads especially, who are also really looking about, you know, creating those partnerships and moving forward. The other really important piece to that is our partners. You know, really having those relationships so that our partners look to us to be able to work with them and sort of respond. And that was one of the things that happened for us again during COVID. Our community partners turned to us and said, we need help. How can your students help? How can faculty help? How can the staff help? But having those relationships ahead of time and really thinking about it, I think is key in, you know, being the amazing public health school that we are, but really thinking about translating a lot of this research into actual practice, especially through our students.
I'll say something about this. It's difficult because we don't have enough support for our students now. And that has gotten a lot worse in this coming year. And so it's very hard to balance all this. I mean, how are we supposed to do all this research, do all of our teaching, train all of our students? It's too much, frankly. I think we're hitting a crisis where we cannot be expected to maintain this level of productivity in terms of research and train all of our students all in the same hat. And our students' funding has gotten really grim at this point. You know, with the whole strike, which was wonderful and more funds for the students, we have the same amount of money available. And so we can't support as many students. And so the crisis in training is really going to be where are we going to support it and where are we going to get the funds to do that. You know, we can try to get training grants from the NIH. They're really hard to get. You know, I have one that's with the School of Medicine and it is about team science. They would not let me put doctoral students on it. So how are we supposed to support all these wonderful students? I don't have an answer for that, but I think that is something we need to take on. To provide training for students, we need funding for students, and the funding is drying up.
Great, thank you. I think we have time for one last question. Yes.
You spoke about the great framework and the whole project to train the follow-up workers in COVID. Is there anything keeping this together so for our next epidemic that we can ramp up really quickly? I'm asking this because in the year 2000, I was one of the bioterrorism preparation epidemiologists at the county health department. And when this pandemic started, I just sort of sometimes felt like pulling my hair out. So I was thinking back in 2000, we had made plans, we had done this, we had done that, but then when, you know, funding gets cut, you know, the California Medical Repository, I found out it would be funded, you know, all these things that it was like, oh, they should do this, they should do that, you know, in my mind, as our plan, you know, time passes, things get defunded. What do we have in place for the next big pandemic?
I mean, that's
We have to start from zero all over again.
phenomenal question. The biggest issue comes back to funding cycles, you know, especially being in disasters. We forget a few years later and people are like, disasters, why would we give money for, you know, whether it's research or practice. But one of the things we are trying to do was the state created a public health reserve corps, so which is something we didn't have before that as a state. We had a medical reserve corps, right? Or we have sort of DVET teams, veterinary teams going out, morticians going out, but we didn't actually have a public health reserve corps. So that's one of the things that we've been working on with all of the local health jurisdictions. And many of the local health jurisdictions, including LA County, have been thinking about creating their own sort of reserve corps and being able to continuously keep, you know, training them, having them ready to go, understanding what it means to be deployed and what that looks like. But it's scary because we have a Pathways program that we got funded for from the governor, which was Pathways into Public Health. Basically, everybody right now that's being trained, how can we, as entry level, have them going into public health? And we just found out again with the governor's budget, a lot of that funding has been cut, right? And it's just about advocacy and being able to do that. So I'm a public health commissioner for LA County, and that's our biggest talk every time on the commission, which is, you know, these cycles keep going and we can't be held to the funding drying up and what that looks like in preparedness, because there will be another pandemic, and not just pandemic, there will be multiple disasters at the same time. Are we ready to handle something like that? And what does that look like when we talk about capacity?
Great.
It is in place. The State Reserve Corps is in place, and there's a place where you can go and sign up and volunteer. Life.
Great.
So right now, basically, the state is enrolling those that are state employees, basically. All agencies, but that are state employees that can actually also be. But it's something that we're constantly talking about. We're in meetings once a week on this, and we're still waiting to see how it will
So
work.
you want to grab Dr. Dorian during the break? Yeah.
I'm ready.
Great. So my most important job was time. So again, I want to thank Dr. Gorbach, Dr. Dorian, and Dr. Jones, and thank you all for your great questions. So thank you so much.